Welcome everyone to our monthly, our every 2 months community of practice session through the GPEC under the IAACD. This is a community of practice for advocates of childhood disability and developmental disability services. Today we have with us Rachel Wright, and she will be sharing with us bridging the gap between families and services, lived experience as more than a story. So you all know the ground rules. We would like to have your cameras on, and everyone's voice is important. So please feel free to participate in the discussions and share your ideas. So the International Alliance of Academies of Childhood Disability is the host of the session, and the GPEC team is the one that you see under here as a constitute of different groups from different countries and academies. And the GPEC is the mother of the community of practice session, and here are the community of practice team leads, and very fortunate to be part of this team. So we are here to discuss around the different barriers that would impact participation and would result in disability. And so we have one of advocates of this service barriers and who have been doing a lot of work through her personal as well as professional experience. So I would like you to meet Rachel Wright today. I'm delighted to introduce her. Rachel Wright is the founder and director of Born at the Right Time. Rachel is a qualified nurse and a parent of a young man with complex disabilities. She is the author of the insightful book, The Skies I'm Under, and hosts the popular The Skies We're Under podcast. As a peer leader, Rachel's passion for bridging the gap between families and services is driven by her powerful, unique, dual perspective as both a practitioner and a parent carrier. Born at the Right Time is a leading voice with a unique understanding of factors that perpetuate adversarial and traumatic interactions between families and services. Rachel and her team are dedicated to using lived experience, research, evidence, and actionable change to positively impact the lives of people with profound or complex disabilities. They deliver CPD certified training on communication and collaborative working with families. Rachel's remarkable contribution have earned her recognition as a finalist for the Commitment to Careers Award at the RCNI Nurse Award 2020 and the National Learning Disability and Autism Award 2022. Her course on communication and co-production was a finalist in the HSJ-based educational program for the NHS 2023, and she recently advised the National Clinical Program for People with Disability in Ireland. Please join me in welcoming Rachel Wright. Rachel, thank you so much for agreeing to share your experience with our advocates here, and I'll leave the floor to you.
Thank you so much for having me. That sounds way more daunting when you list it all like that. Let's be honest, I've just had a toddler on my lap who I was wrestling to persuade that really he needed his nappy changed after he'd done a poo and didn't want that to be done. So it all comes in the context of life, doesn't it? Thank you so much for having me. So I'm hoping that in the next 20 minutes, you're expecting me to talk to you about bridging the gap between families and services. So let me tell you about myself, about my family, and why I do what I do. So Born at the Right Time is an organisation that I founded, and its vision is about to create a world where families of children with and people with complex disabilities feel valued and supported. And we have three aspects: that we support parent carers directly, we train practitioners in working with families better, and we try and influence policymakers and providers to make sure the infrastructure and the systems that are working for both the families and their practitioners are doing so as best they can. And every single course that we do has three vital strands. It has the lived experience of families at its heart, not just my experience, recognizing that I'm of just one story, but many stories. We always look at the evidence, the research, the psychology, the sociology, the things that are underpinning that story, those stories, what are the unseen factors, and then using that information, what happens next and what actionable next change can we bring about together. So as I've so beautifully been introduced already, the posh version of me with the lipstick and the hair straightened is that I do all these things that are supposed to appear slightly impressive. In real life, the toddler on the knee with the slightly full nappy is also a factor of my life. It's a little bit more complicated than some. But we live in the UK, so we have a welfare state, we have the NHS, we have an extensive SEN education, special education support system, and we have social care support. But I'm just trying to pay the mortgage, trying to ensure that we create memories and have a life that is well lived. And then there's the other version that I don't generally put on Facebook and realize that you're now going to share on the internet, which is, you know, the dying the roots, the snotty tears in the corner when it has all become too much. And it is important when we're thinking about bridging the gap between with families and services, that the key distinction that occurs when we are talking about connecting families with services is the people. And the people on both sides of the bed come as their whole selves. They come with the fact they woke up an hour early and turned up to the meeting an hour before, and therefore had an extra large breakfast or a little bit of a nap. They come with their concerns about their family. They come with the argument they've just had. They come with the to-do list that's buzzing around their mind. All of these things make a difference to the way that we human alongside each other, and therefore connect and therefore interact. So I want to acknowledge that I am a white middle-class English woman, British probably, and therefore I come from a very privileged perspective in the context that I'm in. I also have a degree in nursing, which means that I am able to enter certainly healthcare spheres. My husband's a GP, so I'm able to enter those spheres with some language knowledge that means that we can get ourselves heard. But what I hope to talk to you about in the next 10 to 15 minutes now is to look at the lived experience, look underneath the surface of that lived experience, and think about how we use that to bridge the gap. And it starts here. Oh, you can't hear you, but I'm assuming you're all going, this is me and my boyfriend in our late teens. Full cliche, he's a doctor, I'm a nurse. We met years before we even started training. But my dream was that we would go off and save the world, one person at a time. We worked in Uganda, we worked in Rwanda, we did some work in New Zealand. But that was the aspiration. We would have a young family, we would go off and we would, it's a little bit Messiah complex, but we'd go off and do some things. Because I kind of see myself as part Florence Nightingale and part Lara Croft. You know, I've got the care and compassion of Flo, and I've got the kick-ass of Lara in my dreams anyway. But that was the plan, and everybody has a plan when they come out of school and they go into education and they get into relationships and they start having a family. We all design and define what these dreams might be for us, and my dream took a very different turn on the 12th of October 2005 when my eldest son was born. And after a very typical pregnancy, I had noticed the night before my due date, that I had reduced fetal movements. Now I can rhyme off the clinical side of this in parrot fashion. I can sit in any new consultation and I can rhyme off reduced fetal movements, emergency cesarean section, resuscitate. I can do it all. I can do it all. very unemotively, very professionally. But I'm going to give you the under the skin version, because even if I don't express it in a consultation, it is still rippling there. And the emotions do not go away, they do not change. I might be able to manage and control them a little bit differently. But on the day that he was born, I woke up through the night and realized no reduced fetal movements. My husband, I'd woken him up with my cold feet when I climbed back to bed and said, I can't feel the baby move, but I had felt him move the day before. We decided to leave it until the morning. And then the next morning, he rushed off to the hospital where he was working in older people's medicine at the time. And I called up the antenatal ward, and they told me to have some breakfast and come in, not to worry too much. I was strapped to a monitor and told to press that red button if that baby moved at all, and that red button was never touched. And after we were taken into the delivery room, I was examined, and they decided that I needed to have a cesarean pretty quickly, because although they were 90% sure, was the words that they said, that your baby's going to be absolutely fine, let's get them out and just make 100%. So our son was delivered, and the doctor lifted him up and went, "It's a boy." And then there was silence. There was lots of movement of people, but there was no baby crying, and there was no deep breaths. I should have done a content warning for this bit. I'm going to cover some birth trauma. So we're all grown-ups. Misery is optional. You can mute, you can turn off, you can go elsewhere, you can come back. But you will all have seen many stories like this. So my son was whisked off, and I sent him, my husband, to go and check on him and check that what was going on. And he came back and told me that he was not breathing and he needed to be resuscitated. And I managed to be offered up the tip of my son's head as I gave him a kiss, and he was whisked off to the neonatal intensive care unit to be resuscitated. And then I was left with layers of my body being sewn back together. And it was all very surreal. And despite the fact that I had a spinal block, the pain that I experienced was something that I haven't experienced from and since. The sort of the world shifting moment. And this was my bruiser of a boy that turned up when everybody else in the special care baby unit was this slight little dots and tiny prem things. But he looked like a complete hypochondriac filling the incubator, but he needed lots of support and lots of help. And then it was 12 days before he was discharged home with no support, actually. And that was up until the point at which we had an MRI scan. And that MRI scan was done at 10 weeks old, and we'd gone in with a hope that everything would be okay, but we had noticed that his head circumference had waned slightly and wasn't meeting targets. And that was our first indicator that things weren't quite right. So the brain scan occurred, and the consultant ushered us into a broom cupboard. We were completely duped. I know from being an A&E nurse what the room of doom looks like. I know that certainly in the UK, if the NHS has splashed out for some pictures on the wall or a box of tissues or whatever, that the news is not going to be good. But on this occasion, we were ushered into a windowless room, and the consultant sat on the corner of her desk and with the MRI scan behind her and told us about how our son's brain had been severely damaged. And that news shifted everything. We went out feeling like our life had been hit by a bomb, because everything we'd planned, everything we'd hoped, everything we'd thought was suddenly different. And there are so many things that in the book that I wrote, In the Skies I'm Under, I talk about it feeling as though the doctor had conjured up a paintbrush of dripping white emulsion and whitewashing a wall of hopes and dreams that were once colourful and expectant and diverse, and suddenly were void and vacant, and rather than full of potential, felt really suffocating and unknown. There are as often the case for children with very complex disabilities, there isn't just one diagnosis, there's many diagnoses. You fall into a rabbit warren of diagnoses as it evolves over the coming years. And I remember the consultations. I remember the first time someone used the word disabled, or used the word wheelchair, or used the word palliative care, or used the word epilepsy. The equipment, when everybody else is choosing giraffes and rainbows on their baby equipment, I was choosing 4-point harnesses and foot plates and headrests. And my experience in family just felt so different. And then came along the hypervigilance, the kind of trying to be check everything was happening and being sure that everybody was doing everything they needed to do, and the fighting that ensued to get services and to get things. And I remember how people made me feel. I might not remember all of the words, but I remember how they made me feel. And this is my son's day now, although actually he doesn't go to school anymore. So this was his day about a year ago. And we're in a very privileged position that we're in the UK, which means we have lots of different pieces of equipment and services and things. But he needs something done for him to keep him alive every 30 to 40 minutes. And when he is at school or being looked after by somebody else, I'm ordering prescriptions and syringes and chasing GPs or liaising with clinics and orthotics, or the OT or the epilepsy nurse or the neurologist, or managing equipment and getting pieces of equipment serviced and adapting clothing and liaising, because I'm constantly being chased, required to prove, explain, justify, and prepared to be scrutinized by everybody. Is he sick enough for this intervention, or is he too sick for this thing? Can he be eligible for this intervention or not? I'm going to ask you a question. You can pop it in the chat or unmute yourself. How many people do you think I communicate with about my son when I counted it a couple of years ago?
50.
Thanks for that. Higher or lower than 50? That's a
I'll go
UK
with the
reference.
maximum 80. 80
30 to
plus.
50, 80 plus. Yeah, so here we go. When I sat down and worked it out, it was over 80. And these are named people that I know the names of. There were also people who left their jobs, and so somebody else came in. So there may be 80 positions, but that person may change. You get used to one doctor, you get used to one clinician, you get a rapport up with that particularly specialist nurse, and then they have changed, and you have to start the beginning by retelling your story because it hasn't yet been captured, and the trauma that occurs with that. And on one particular day, I sat and I worked out. I was sitting at this desk. I was working from 8 till 5. It was a couple of weeks before my son had spinal surgery. And these were all the interactions I was required to do. And I recognize from a privilege perspective, the capacity required to do all these things. So there's emails, there's apps, there's telephone calls, there's chasing people, there's coordinating people, there's passing information on. You can see in that image, all the lines come back to me. So we could put in some lines across that web, but actually, mostly it comes back to me. So what's the unseen reality? The research shows that for parent carers, when we're thinking about their well-being, that there is an impact on their well-being by the child's impairment, but actually it's the context that has the biggest impact on parent carer well-being. And the reason I do the things that I do is because you can do all sort of newfangled therapies or day trips or specialist equipment or all these things, but the single most important thing to my life, to my everyday, is the ways in which people communicate with me and work with me when it comes to caring for my child. Whether I feel like I'm having a conversation of curiosity and warmth or scrutiny and judgment. Whether I'm being assumed to be capable or assumed to be mistrusted. All of these things make a difference to my capacity as a parent and my success. Because what it can feel like is it can feel like we live in a goldfish bowl that represents the toxicity of a very complex system that's observation, scrutiny, and regulation. And I can I can, as a clinician, I can understand and justify these levels of observation and scrutiny. We need to know the details. Can I be sure that's really a seizure, or do they think that it is and it isn't really? Or how can I be absolutely sure that this treatment is really required if I haven't got evidence? That they layer up, and it can feel like I'm doing this frantic, incoherent supermarket sweep where you're being asked to go and get this, all these different things. I'm getting instructions from so many different practitioners, and I can feel bewildered and dazed. And I'm standing at the checkout with all this trolley full of stuff thinking, I haven't got the capacity, I haven't got the time. And then I end up leaving things behind. And when it comes to that context that feels a pressure and impacts my wellness, I think about the level of trust that I experience, because I think there's a power imbalance, and an imbalance between the amount of authority I have, which is very minimal, and the amount of responsibility that I have, which is a lot, and the disproportionate expectation of trust. I'm expected to trust the services that support my child and my family, but they are not expected to trust me necessarily, because I need to prove, I need to show. And I love this Charles Feltnam definition of trust, that it's choosing to risk making something that I value vulnerable to another person's actions. And every time I step into a clinician's room, I'm risking my most precious thing to their opinions, to their decisions, to their insights. And trust isn't something that is, I've got that marble jar up. It's a Brené Brown reference that she talks about trust being moments of connection rather than something that it's not just because you wear a lanyard or because you have a title, but trust is built up by moments of connections. It can be a smile, it can be an interaction. I've recently on the podcast, we did a whole series on trauma. We looked at parent carer trauma, we looked at parent carer suicide rates, which is equal to those of veterans. We looked at systems generated trauma. So how within trauma-informed practice, how much are systems and services and practitioners thinking about the ways in which their systems further traumatize parents by the ways in which they're scrutinized, by the ways in which they have to navigate through that system. And there's emerging research about that from Dr. Clements over in the UK and Anna Yellow, who came onto the podcast. And it's recognized that the trauma that is experienced by parent carers and families is heightened by the systemic and cultural privilege and bias and power imbalance that exists, certainly within the UK. Our leader reports, our learning disability reports show that. So there is a gap. So how do we bridge it? How do we use the information of that lived experience, not just as a person's story, but understanding the context to think about next steps? We need to reframe. Are we talking about a non-engaged parent, or are we talking about insurmountable barriers? Language barriers, appointment barriers, getting to hospitals, navigating the complexity of systems, communicating between services. Are we thinking about a difficult parent, or are we talking about a traumatized parent who is hypervigilant, who is experiencing complex PTSD as a response to their child? I have a small initiative called Don't Call Me Mum. One of the simplest things you can do in an interaction is use my name. I'm always taken aback when I phone up the insurance company and at the end of the phone call they say, "Is there anything else, Rachel?" And I'm like, "How do they know me?" I was like, "Yes, I've given them my name right at the very beginning." But names, and the research shows different percentages of parents that would prefer to have their name or not. But it's in the UK there's a hashtag call me, because your birth name might not be the name that connects with you. The dementia patient on a ward might be known as Bert, and if everybody's calling him Joseph because that's what's on his medical records, then he's going to have no idea what's going on. But for a parent who's navigating this sea of complexity and jargon and policies, a name cuts through that sense of powerlessness and connects to my humanity once more. I had did some training recently, and one of the delegates talked about how if you have a good consultation with a parent carer and a child, that would mean at the end of that consultation, you'd know what to buy that child as a birthday present. You'd know one of their favorite characters. You'd know something nice about them. And that's all about connecting with the humanity, taking our humanity and their humanity and finding that bridge and finding that connection. It's about moments of interaction and meaningful connection. Because if we're talking about empowering people, we need to empower them not just with our words, but with authority, with agency, and with resources. Because without that authority, agency, and resources, empowerment simply becomes abandonment. There you go. You do it all. But if I haven't got the ability and I haven't got the skills and you've not given me the words and you're not giving me the insights and you've not given me the resources, I've just been left alone. One of my leave you with this very quickly, that I have this feeling that so often multidisciplinary teams work as toddlers in a sandpit rather than Dungeons and Dragons players. So my 2-year-old will go off to nursery. I'll pick him up and I'll say, how'd you have a good day? And he's like, yes, I played with Jimmy in the sandpit. And Jimmy and my son will have been playing in the sandpit, but I look at the photos and they're just playing next to each other. They're not actually sharing toys. One's got the digger and one's got the truck. And my son actually in this room plays Dungeons and Dragons with his friends. So he creates the world and the players come in and they change, their characters change their story. The characters come in and they roll their dice and they impact the story that the storyteller is changing. And that's what MDTs are supposed to do. Find out what's the heart and the message and the core of that family's life and that child's life. And how do we improve it? How do we change it? But so often I think MDTs and multidisciplinary teams are simply silo working in close proximity to each other. We're all just doing our own jobs, but we've sat around the table and done our own jobs. So how do we think about the infrastructures and the systems that impact the ways in which we can collaboratively work together? I'm going to share with you, can you pause here for me, please? And then this is a really short, well, it's a few minutes long photo documentary. And as Brené Brown says, an unclear is unkind. Does anybody have any questions?
Thank you so much, Rachel. That was really heart-touching, and thank you so much for being so courageous to share your journey, your story, and how your life changed. And also I learned a lot from what you have been saying, and especially the part that you mentioned about using names. That really highly resonates with me in my practice, and that was a great learning point for me. If you could stop sharing, then we can see everyone.
Oh, yeah.
And we can have a discussion. We have 24 participants in the room. I would like to keep it within one room and have a discussion with you here. Yes, please unmute and go ahead. Please express your thoughts, your questions. Meanwhile, while people are gathering their thoughts, maybe I can ask one question. Rachel, I know you've shared a lot about your experience and your journey and how your dream has changed from what you have as a goal for your life, and then it significantly changed and you had to change your path. And that was also something that highly resonates with me. So I was really touched by that. So I wanted to know what helped you thrive through that change and come to this a very different but differently successful and widely useful.
I remember washing up my son's syringes when he was very, very small and saying, I'm never writing a book. I'm never going to be useful out of this. I was absolutely determined that this was not going to be some, not going to be a new story arc in my life. But I guess I'm a bit of an agitator and always have been. And I took to just looking after my child and continuing to be a nurse for the first 10 years or so. And then 10 years ago, I published my book. And from that, I have been sort of using that lived experience, understanding. I've, fallen down my own rabbit warren of the research and the evidence about connecting that lived experience about the context and trying to really understand what's going on. But it's just been a very slow evolving thing. It's not been any particular light bulb moment. I probably fought it quite a lot of the way.
Thank you. Thank you, Rachel. Yeah, I see Arnav, you have your hands up. Please go on.
Hi, Rachel. I'm Arnav. I'm a developmental pediatrician from Leeds. Now, thank you for sharing those messages and the story. And I think the point you make about the communication and connection, which is so important. And of course, the other ones around being clear, being kind. One of the things that we certainly within the UK see progressively is the teams becoming more and more disjointed because of the way things are going. The money is following specific directions and the things don't join up. It's really hard to see how we can influence that process because money is tight and people just go down those rabbit holes of wanting to save as much money as possible. It's fantastic that you're actually making a difference by running the courses, by doing things. And I know that some of the other agencies, whether it's the British Academy of Childhood Disability or the a number of charities, are trying hard to influence politicians, but we're actually probably not getting anywhere. What do we do? Where do we go?
I think I think in our pursuit for specialism, we've missed the specialism of generalization. That actually generalists are what my son needs. Like, he has lots of complex things, but actually he needs somebody who's going to not look at him as a bundle of bones and ligaments and organs, and because especially now he's in adult services, that's even worse.
That's worse.
So I think it's about our reality matching our rhetoric, because our rhetoric is all around prevention, our rhetoric is all around holistic, our rhetoric's all around empowering, but actually we don't put the funding to match that, because we put the funding into acute, fixable, origin NHS type, which is you put them in, you fix them, you move them out again. And that's how we're still doing it, even though we have a very different cohort of population with very complex disabilities that don't fit that model anymore. So you're right. I don't know what the magic wand is, but I think it's something around the specializing generalists probably, and reducing the funding streams. Like the number of people I have to speak to about one aspect of my son's care is ridiculous, and it makes it impossible to navigate. But if you work it out, then let me know. I'd love to know how to
been trying to for a while.
Thank you so much for your question.
Thank you so much, Rachel. I see Peter, your hands up.
I'll try not to fangirl you, Peter.
We have the answers, but we don't want it's bad for business. Thank you very much for sharing. That's a very heartfelt. Thank you. Just in the context of what Arnav was asking and what you were saying about prevention, I wonder if we can frame some of what we're trying to do in terms of both of primary, secondary, and tertiary prevention. You talked about, for example, the remarkable challenges that parents experience and the physical and mental health toll that it takes on them. And I wonder, and we've been doing some work in this to try to prevent some of that morbidity.
Yeah.
Uh, and it might be worth trying to use the language of public health as one of the frames through which we talk about what we're doing. Um,
Yeah.
we don't cure very much in medicine, and that's a rude thing to say, but we could perhaps reframe our approaches to things. Chris Morris's work in connecting families is another example of prevention.
Yeah, and I think it has to match the complexity of the system we're in. Like if we're going to start picking it, making small changes, then it has to be those sorts of things. I think there are so many sort of pockets of experience for families. So we start, or often we find ourselves in a very acute setting, and then we end up being out in a community, and it can feel like we're utterly alone. I recognize that as a doctor and a nurse, we had a very different experience for that. So, but lots of my peers were like, I don't know at which point I start calling somebody, and I don't know at which point I start, and 1 minute we've got a team of however many people coming in every 2 to 4 hours to take measurements of things that I don't even know what they were. Never mind how I do that. And the preventative component of them being in community services, it is so hard to get proactive community support, whether that's around postural care, whether that's around your changing and breathing, whether there's so many components, the neurodisability side of things, whether it's tension and muscles, and it's so much harder to do that than it is to get an appointment into an orthopedic spinal surgeon and get someone to book a massive surgery. um I don't know how, other than, and potentially it's about recognizing there being a cohort of families of children who need an entirely different approach, because we're not fixing and sending off. That's not what we're doing. So how do we? But the system still functions. Like, it's in the UK, even like the funding of all of that. At one point we had my son had hip surgery, and then he subsequently did some spinal surgery, but he was seen by the neurodisability consultant, but they said, I'd be better to see you with the spinal surgeon, but you need to go back to your GP, and your GP needs to refer it back into the same hospital, and I'm part of that same team, but it's with a different consultant, and there's a 3-4 month wait, at which point his scoliosis has dramatically changed because he's gone through a growth spurt and he's not got the appropriate equipment at home, because his wheelchair is no longer supporting him the way it should. There's just so many pieces. There's so many pieces to that experience. So I've no idea is the answer to that question. Sorry. But again, I'd love to know, how do we reframe that preventative, that how we talk about that stuff in a way that makes sense.
Thank you so much, Rachel. Yeah, that's really helpful to hear the view from your standpoint. I have Bonnie, you have your hands up. Please go on.
Hi, Rachel. My name
Hi.
is Bonnie Wooten. I'm a shared decision-making decision coach in a children's hospital. Your story is very moving, and one that certainly I'm familiar with as a decision coach working in an organization. I do a great deal of education of staff around some of the issues that you raised. Also, I work with youth, and as they transition into the adult life, and try to help families facilitate how to consider decision making, the questions that you need to ask, the questions that are important, so that you feel valued, and that you feel that your questions have been answered, and where to go. The multiple physicians that you have is not a new piece of information for me to hear, and I try to work with families to streamline that, so that you have one person that you talk to that can give you information and direction. it has been working fairly well at Children's Hospital. We've been in operation since 2018, was brought into Children's. And so I do a great deal of work in the organization and in our province, working with families such as yours. And I do know that we have been involved with Dr. Teague since she's joined us as well in some of these events to be able to share information. And I think, that there is a way that each of these organizations that are even on board listening could take a look at this type of support in their organizations. And it's a way to facilitate parents' decision making. It's a way to help you look at options. So, and what are the risks and benefits of each option with the pros and cons? What do you value most and what fits with your life right now?
Yeah.
And then come up with, a preferred decision so that you can move forward. So a lot of your story does resonate with what I try to educate. And work with. I also work directly with parents on referrals, so that I can assist them in moving forward with the decision that's right for them, and not necessarily that what's right for the physician that's recommending it, but also ensuring that the child is not at risk when you make that decision.
There's lots in there, isn't there? Because around the shared decision making, I talk lots about that power imbalance that inherently exists, and I think because very often parents of children with very complex disabilities start off in a very medicalized acute service, that we ourselves become quite institutionalized and medicalized, and we can become very fearful of doing anything or changing anything, and we read off all the risks, and the risks get flipped. When my son we were talking about whether or not he would have a blended diet. Like, I wanted to pursue blended diet, but the doctors were doing investigations to give him a JEG rather than a PEG, and I was having to sign a form and have my kitchen inspected to say that he was at risk of all sorts of things if we went for a blended diet. But nobody had to justify to me or quantify the risks of doing things. I think sometimes the risks of doing something is often questioned, but we don't have the same measure of looking at the risks of not doing anything. We don't give that the same focus, and as parents, we don't get the debrief after a stressful conversation. We don't get the debrief. We don't get the water cooler moments to talk over something that's happened. We get Facebook forums which egg us on and whip us up and widen the gap between us and them because they don't know what they're talking about and all this kind of stuff. So that shared decision making has to also come from the parents respecting and honoring and amplifying the voice of the expert voice in front of them, as well as understanding their own expertise. But I think Brené Brown says, strong back, soft front, wild heart. We go in knowing what we know, but we go in recognizing that we can change, have our mind change and have our perspective changed. And we're ready to think creatively and think outside the box, which is all that you're talking about in shared decision making. But it's that power imbalance. Thank you, Bonnie.
Thank you so much, Rachel, and thank you, Bonnie, for speaking. I was wishing you speak, so I'm happy that you shared that, and it was through our session on shared decision making that I got to meet Rachel because she was interested in the shared decision making model. Yes, Chris, I see your hands up. Please go on.
Thanks, Eliminesh. Hi, Rachel.
Hiya.
I've been a big admirer of your work for many years. So,
oh, thank you.
I run a childhood disability research group called Pen Crew down in the University of Exeter.
Ah, yes.
And I think you've spoken to one of our PhD students, Jim, who's doing some work on parent care empowerment. And we loved your piece in the BMJ, which I strongly recommend. I'm not quick enough to find a link to put in the chat for everyone, but it was all this work to empower parent carers rather than why don't we just stop disempowering them through the system
in the first place. Yeah,
exactly. And whilst I share that wholeheartedly, we are in this imperfect world with the financial pressures, as Arnab says, that just constrain everything we do, and historical systems. Some of what you're advocating, Peter was advocating over 30 years ago in terms of family-centered services, about respectful and supportive care, treating parents as the experts in their own children, and yet we still struggle with it. I have witnessed the resilience that comes from parent carers connecting with each other, that community resilience, which is a recognized part of public health, however you define the community. It's the people in your neighborhood or people with a shared characteristic, shared social identity, how we can cultivate that, and how we can create or reduce the adversarial nature of what goes on, because that's what I've seen damages parent carer health and damages relationships. It's how to reduce that adversarial nature of parents fighting to get what many professionals would think you should have.
I think there's three things that would make a difference to that adversarial culture, to that sort of rhetoric around fighting. And well, first of all, we could stop using the rhetoric. Like, we talk about frontline services. Why are you frontline if you're not in the trenches, unless we're purporting for that to be the case? So we've got to reduce that implementation gap, or else because it's the parents that stand in the gap. So the gap between this is what you're eligible for and this is what you can get, and this is what you actually get and what you actually experience, because that is the hotbed for discourse and for a culture of dissent. But I thought I could choose which consultant I had. I thought I could make this decision about my child. I thought I could choose. And then, I think the other thing is the inherent ableism within our world, within the infrastructure of our medical services, where the pursuit, I've got a brilliant interview with Amy Hogan coming out in a few weeks around the toxic pursuit of physio, and what does that tell our disabled children if we just spend our whole lives trying to fix them? We spend so much energy and so much time and so much money to make them something different. What does that do to their self-worth, and what does that do to their identity? And that's our own inherent ableism. And then I think the third component is there's the implementation gap, there's the ableism, and then there's the trauma that's experienced. And there is this initial flush of, this is not the world I wanted. And then there is however many X number of years before parents adjust, adapt, change, some to better, on better days than others. But how do we help people through that process? And I think that is by there being a default of psychological support for parent carers at the point of diagnosis, an opt-out option. You are going to need support because this is life-changing, rather than we're going to wait until you're falling apart and then we'll hang around and give you a 6-week CBT thing at some point when you're in bits, because it's coming into every interaction with that hypervigilant, complex PTSD, stressed, traumatized state that amplifies. So so you've got the ableism, you've got the implementation gap, and you've got the trauma, and it's a perfect storm.
Yeah, no, you sum that up well.
Thanks.
So we've developed a Healthy Parent Carers program that tries to help you. But you don't recognise you might benefit from something like that until this adversity's happened.
Till you're worn down, till you're weathered down, until you realise the system isn't going to serve you in the way that you thought it was going to. Yeah. Again, there's another episode coming out soon of a parent who worked within NHS England in the UK, and then her daughter died, and it was the unraveling of, but I thought I spent my life working in this system and I thought this was going to be here for me, and it's not.
Yeah.
and the unraveling of values, of expectations.
Oh, this horrific. I mean, Sarah Ryan's
Yeah,
stuff. Whose son died, and when
yeah,
being looked after, and that's just like one of a number of stories
yeah.
that the Justice for Laughing Boy
Hmm.
creates and beautifully communicates. There's also sort of Peter's led some work to create the Envisage program, which is trying to prevent some of this stuff coming later on. So, introducing a more positive perspectives
Mm.
and emphasizing the importance of looking after yourself as a parent carer. So we battled to make these available, but the resources limit that. So
Mm.
you don't want to you want to try and stay optimistic and positive, but I think we just have to foster the alliance for those of us that support what's right, and we keep banging the drum. But I think it is challenging.
And and that's why my organisation does it on those three levels: support the parent carers directly, try and transform the way services are delivered through the ways in which practitioners interact. I do 7-hour 1 day training that has that lived experience that peels back so many more layers, and then brings in lots of different ways, and that we can bring about lasting change. And then the systems side of things, the changing systems and services, because if you want to be collaborative or whatever, but actually the panel says no, or the appointment comes and every time I want to change the appointment I have to phone up the hospital, but it's always an answering machine, and then they'll form, there's so many ways in which really practical things can make my experience of navigating that system traumatic, because it's that powerlessness bubbles up again. Thank you.
Thank you so much, Rachel. I was gonna give you the chance, Arnab, anyways, because I
I just wanted to comment on that, and I think we all, reflecting on what you've been saying. Certainly, I mean, the systems are really constrained, but also all of us who are involved and who are in this field, we really need to get an understanding. So people's attitudes can be different. People can, in spite of limited time, limited resources, people can still make a difference. And I think we all recognize there are different people within all teams, and people make a beeline, and then all that happens. But as a profession, I think, or in our field, one of the things which I'm certainly really glad which is happening both within our academies of childhood onset disabilities and our international alliance is that we are increasingly having these shared conversations, and we are bringing together a forum, whether it is forums like this or even within our conferences. Now, a lot of our conferences, we want people with lived experience and families to be part of, to be within the scientific sessions, to challenge and to bring their perspective. And certainly it has, over these last few years, enriched our conferences and conversations much more. But we need to really make that happen even quicker. So we really look forward to you contributing. When I say you, everybody with lived experience coming through much more.
I think the challenge, though, is turning that lived experience into meaningful insights. I think I fear that sometimes the lived experience story is there for the story. It doesn't, if we are matching our again the rhetoric to the reality, how much does that story take precedence within the delivery, and how much does that influence the ways in which things are done? And it's a skill to translate. It's understanding the layers of that story. It's helping the person understand, all the stories that I share, the small library of stories that I've got that we deliver with our training, they all have certain components and certain messages and certain things that we're like, and that translates to, this is how we can do it differently to make it different. Because otherwise it becomes pity porn, for want of a better word. It becomes that, show up of someone's life so we can all feel nice that we're doing these great things, rather than this is the story. This is what it means. This is what's going on that I'm not seeing. These are the untold stories within that story. And this is how we can make it different as a response to it.
We are trying, Rachel, and
Yeah, no,
I know
and
Peter's
I'm
got
not
his
saying
hand up. No, let me
I
just
sounded
tell
way
you.
more
I
critical
think
of it.
I'm going to
But
use the
it's
forum. I'm
yeah.
going to use the forum to just mention a few of the things that's happening, certainly within the International Alliance. Apart from this, we are looking at how, and we've got a working group of people with lived experience, and we are coming up with a framework by which we can actually make a difference. And certainly the other organization where a lot of work is happening is within the European Academy. And we are hoping that we're going to be able to make that exact difference which you talk about. It's not just a story that we want to hear.
Yeah.
We want to actually take it then onto how does it make a
Understand.
difference? How can we make it
Yeah.
better?
Yeah. Yeah. And I think there's lots of emerging research around that. There's Lorna Fraser within the UK doing lots more research that's highlighting. And unfortunately, that's also a component that needs to be added to make people stop and listen. As far as, you know, the evidence, and you also probably need some economic standing around why it's worth financial worth while doing it differently. How much time and money and energy we're wasting when we don't get that shared decision process, and we end up doing something that's completely out of sync and out of line of what's right for that family in that situation, and the waste of finances. Thank you. I'm delighted. I'm thrilled about this group. I'm excited to know all of you guys are doing stuff. I'm on the outside generally now, so
We are thrilled by you as well, Rachel. Peter, I know your hands was up. Like, if you want to use a few seconds, I know.
Just a thought that it would be very helpful when parents like yourself are identifying challenges to also talk about how else this could have been done. Because most of us do not have bad intentions. Most of us are
absolutely
ham-fisted and uneducated and uninformed about how else to do things. And so if every time an issue is described as having been done less than ideally, and I hear you say, people like you say, this is how it could have been done, I then am learning something that I hopefully will be able to apply next time.
Yeah, and the training that I deliver is full of that stuff. So little things from one-page profile for families, so that it's not just a child-focused thing, but who are the people, who are the networks, where's the values, where's the current priorities, to clinicians helping to write out the diagnosis story in a way that the parents can go to a new appointment and hand over a piece of paper that says, here's all the information you need to know, and I will give you anything that's not on there. But I'm not retelling this story again because I find it traumatic. I'm not covering this first time we had seizures. I'm not covering whatever, but I've worked with teams and they have set up systems whereby they've put those things together for families, and down to families parents having like their email signature saying, I don't work on a Wednesday. I'm not dealing with my child stuff at all on a Wednesday because I'm protecting myself, you know, and out of office for medical things. And also things like, this is my one-page profile. Don't book me an appointment at school run time because I get the bus. 2 buses to the hospital and I simply can't do it. Please text me the morning of my appointment and make sure. There's lots of different ways. There's lots of templates and stuff and different ways that we can make things easier on both sides. Absolutely. But that's it. It's I'm not into campaigning. I'm into positive actionable change. That's through not this is wrong and you need to fix it, but this is wrong, and I think this would have been a different experience if it had been done this way. The caveat to that, though, is I think there are sometimes some experiences are traumatic, and we will always imagine if it was done differently, it would have been better. But actually, in essence, it was a traumatic experience, and no matter how it had been done, we would have gone away feeling broken and sad. And therefore, I think, you know, sometimes there is a caveat of I'm not sure there is a perfect way of doing something that is essentially life-changing. I think there's better ways, but there's not a perfect way.
I wasn't suggesting there's a perfect way, but if I understood the impact of what I said and how, and you
Yeah.
say this is how it could have been done, I will then probably learn from that.
Yeah. Thank you so much.
Thank you so much, everyone. I know we are a little bit over time, and thank you so much, Rachel, for sharing that experience. And Peter, with regards to your question, we can always bring back Rachel and in the context to discuss more about how else we could do things differently. And Rachel, you can share some of your work from Born at the Right Time and help us navigate those questions. Thank you, everyone, for your active participation. Our next Community of Practice session would be May 27th, and we'll see you in 2 months' time. We'll keep the discussions behind the scene, and we'll try to bring back Rachel. And I know Chris also might have some few ideas you wanted to share. So we'll just end it by the hour, and we'll bring Rachel back for further discussions. Thank you so much, everybody.
Thank you so much for having me.
Thanks, Rachel.
Thank you.
Yes.